Hi, everyone. Thank you for taking some time to spend with me going over some of the most interesting publications that came out in the last couple of months. It's a very, very busy time. There's a lot of medical scientific information that's being shared, obviously because of COVID. We have particular interest in that. So I wanted to share with you some of the key things that came out. I think we really are at a point where there's a greater clarity on a lot of the questions that we've been asking for quite some time. So let's get started, and I'll share those slides with you so you can take a look at that as I describe some of the findings. So I think the first topic that I wanted to cover is a question that we've started to ask ourselves, more than 3 years ago, and this is really what is the connection between MECFS and long-COVID. And so, as you can see, this publication came out a couple of weeks ago by two of our most important thought leaders in our space, Tony Komarov and Ian Lipkin. And in this case, the title says it's all. The title of this article is MECFS and long-COVID share similar symptoms and biological abnormality. And so they really they looked at a large number of references, nearly 500 articles that they cover in this review. And here's really what they tell us about the similarities in symptoms. So as you can see, they compare MECFS and long-COVID. And there's almost a complete overlap. In fact, the only symptoms that have been discovered or have been described in long-COVID, but not in MECFS, is decreased smell and sense of smell and taste. That seems to be quite unique to long-COVID, as well as rashes and hair loss. They also note that painful lymph nodes, chemical sensitivities, and tinnitus were observed in MECFS, but not in long-COVID. I actually disagree with that, and I think we are aware of cases of these manifestations in long-COVID as well. But I think the bottom line, irrespective of those slight differences, is that there's a significant overlap between MECFS and it's a subset of people with long-COVID. So here's really an important study came out again about 3 weeks ago, and it has already created a lot of noise. And so I want to get into that in a little bit more detail. This publication was published initially online, and then more recently in the actual journal JAMA, the Journal of the Medical Association. And this is the first data coming from the RECOVER study, this big NIH initiative that we all know about, funded by more than $1 billion, coming from a lot of our work in Congress back at the end of 2020. So finally, we get some data out of this study, which is this large NIH-funded study. And the title of this paper is the development of a definition of post-acute sequelae of SARS-CoV-2 infection. The shortcut for that is PASS, and that's really the NIH term for long COVID. So what did they do? It's kind of an interesting study. It's not intuitive, but the goal of this paper was to find a way to distinguish between people with PASS or with long COVID and people who didn't. And so the way that they approached this question is they looked at 10,000 adults from the RECOVER cohort, and they compared people who had COVID to people who did not have COVID. And out of the more than 200 symptoms that were described by people with long COVID, they selected the 37 symptoms that occurred in more than 2.5% of people. So already, they kind of narrowed it to the more common symptoms. And then they looked at those and really asked the question of what symptoms really help us to distinguish between people who have long COVID, people who had COVID and then developed long COVID, and people who didn't. And so as you can see, this list really gives a score to the symptoms that were most helpful in distinguishing between people with long COVID and people who don't have long COVID. And the number one symptom is the smell and taste. So in this case, they give it a score of 8, and ultimately to meet the criteria for long COVID, you need to have 12 points. So as you can see, these 12 symptoms, if you lost your sense of smell and taste, let's say, so you get 8 points, and you also have chronic cough, bingo, you have long COVID. But you could also, for instance, have post-exertional malaise, brain fog, and fatigue and dizziness. And then you also qualify to get this definition of past or long COVID. So it's really not about severity. It's not even about the most common symptoms. It really is about what is most helpful to distinguish between long COVID and people who didn't have long COVID. So that's why the smell of taste is so, is so important, but also is post-exertional malaise. So very interesting. There's been a controversy in the community. A lot of patients feel left behind because they have symptoms who are not included in those 12. So they're concerned that they're not going to be viewed as having long COVID. So I think we need to understand that this definition was developed for a very specific reason. It is not a clinical definition. So more interesting, I think, is really this table coming from this study that looks at clustering of patients. So what they did here is they started to kind of look at this kind of a table. It's called the heat map, and the darker the color, the more the greater the frequency is of a particular symptom. So let's just look at this cohort number 1, the one on the left, where you can see that 100% of people had lost their sense of smell and taste, and you can see that this cohort is quite different from the others in the sense that these people had didn't have, for instance, as much post-exertional malaise. They did not have as much changes in terms of cognitive dysfunction and things of that nature. So to me, this is probably the group that is sort of the almost pure long COVID, the one that does not look that closely or is not as closely similar to what we would call MECFS. These are the cohorts 3 and 4, at least in my mind, are what we would say, yeah, these are people with MECFS, perhaps with a bunch of other symptoms, but primarily this is really a cohort that is very reminiscent of MECFS. So why do I say that? Because almost 100% of these people have post-exertional malaise, the hallmark of MECFS. Clearly, they also have, brain fog, in this case, dizziness, and some also some gastrointestinal issues. That's cohort number 4. So, to me, this is much more of the MECFS-like cohort, a subset of long COVID. Cohort 2 is probably one that I would say has more dysautonomia, features of dysautonomia. We have some of those aspects like dizziness, palpitations, things like that. So you can see there's a significant overlap, but clearly you begin to see some clustering. And when you put those numbers together, I think it becomes quite clear that while this is not reported directly in the data in this study, I think we can figure out that probably between 50, maybe 75% of people would meet the case definition for MECFS. So again, coming from the RECOVER study, we now have greater clarity on what the overlap is. This was actually described in another publication that came out in May, from David Petrino at Sinai. Those of you who watched the video of the webinar that we did with Bio, David Petrino presented on this question of how do we clinically define people with long COVID, and he had at that time shared with us his perspective, which is captured in this Venn diagrams, and this was recently published. And what David is saying is very interesting. I think in his mind, there's a group of people that he describes as non-syndromic. These are people who have essentially an organ injury. So it could be, kidney disease, it could be pulmonary fibrosis, or a lung disease, or cardiac disease. And in this case, these patients really follow a different trajectory, and they would be helped by interventions related to these diseases. At the same time, there's a group of what David calls the syndromic long COVID, which is much more reminiscent of MECFS. And unfortunately, as they describe here, mainstream tests do not necessarily correlate with the presenting symptoms. In other words, the simple blood tests or other tests that are routinely done will not really identify a specific difference. So it's MECFS, it's post-exertion exercise, a reduction in exercise tolerance, dysautonomia, autoimmunity, and could potentially be worsened by pre-COVID MECFS, by mast cell activation syndrome, Ehlers-Danlos syndrome, chronic Lyme disease. All of those with, in the context of COVID, really are presenting with worsening of symptoms. Petrino also describes this group that he calls the red herrings, and these are people who are just, they need more time to recover, and that could be, as long as a year, maybe even longer than that, but eventually will have their symptoms resolve. So I think that's a great visual to help us understand the similarities, the differences. I suspect that if we wanted to be true to the size of these groups, there's probably the syndromic long COVID is probably greater than the group with non-syndromic. But that's probably something that we're going to have to figure out over time. I have to say that Ani, our communications manager, created a very similar Venn diagram almost 2 years ago. We didn't really have all the data at the time, but I think conceptually that's what we felt, that there's a significant overlap. So I think that this visual is really going to be helpful as we talk about the similarities and differences. And I can't help myself, but going back, even further back in time, and remind ourselves that back in May of 2020, to be more exact, 28th of May, that's when Representative Jamie Raskin presented on the floor what we called at the time Understanding COVID-19 Subsets and MECFS Act. And really was the brainchild of Emily, who worked on that well before we even knew that long COVID is a real thing. And so I just, I thought it would be helpful for us to remember that that was something that Saul had worked on very early on, and I think that was an important contribution. Ultimately led to the funding for NIH and other things, but it's just interesting that we already used the term subset, more than 3 years ago. So that's kind of on the really emerging data on the similarities between MECFS and long COVID, and a better, more precise way of talking about that. The other interesting literature that I think begins to be out there, and I guess you're going to be hearing me talk more and more about Epstein-Barr virus. I think at this point it's quite clear that EBV is rearing its ugly head in the context of long COVID. And here on the top you see a table from the paper by Lipkin and Komarov. and they talk about some of the mechanisms. And so you can see that on the left-hand side in MECFS, obviously there were a number of positive studies that showed EBV as the pathogen that's related to MECFS, but there were some negative studies as well. And in the context of long COVID, you can see that it's also true. Reactivation of EBV is frequent or or measurable, and as well as other herpes viruses. So let's just look at some of these studies in more detail. This study came from a group in Serbia, and they showed that in a number of studies, again, there was a 6-time higher chance of reactivation EBV in patients with severe COVID and compared to non-COVID control. So this is more in the setting of disease severity, which also has implications for long COVID and the development of those other symptoms that we talked about. But let's look at specifically a group of patients who are not hospitalized. And this is a wonderful study, probably the best study coming out of the group at UCSF. And that's very interesting because really these investigators were primarily HIV experts. And very early on in the pandemic, they kind of transitioned to their work to look at COVID. So this is a cohort of 280 to 280 adults that had COVID-19 and developed long COVID symptoms. And so we do have a history on those patients because they were followed in this HIV clinic in some cases. And so what the researchers did here, they performed blood tests looking for EBV and CMV. And they did that with the routine commercial laboratory tests that we have available. And what did they find? They found that the long COVID symptoms such as fatigue and cognitive dysfunction, they certainly were correlated, and they looked at least 4 months after the initial diagnosis of COVID. They were associated with evidence of EBV reactivation. So they're looking at those antibodies, and there's an increase in those antibodies, and we can see that in the blood. But actually, it was not correlated with EBV viremia. In other words, we cannot really measure EBV directly in the blood. So it's really reactivation of the Epstein-Barr virus. And when we do that, we really see a very strong signal. Basically, we call it odds ratio of 2.12. That means there is a twofold increase in these long COVID symptoms if you had the reactivation of EBV. So it's not everyone, but it is way more frequent in those people who had EBV. Interestingly enough, HIV infection was also correlated with neurocognitive dysfunction, and that's something that we see now when HIV/AIDS really has become a chronic disease. And so we see people who are surviving for much longer, and the underlying HIV infection is also causing those neurocognitive dysfunction. As a side note, it's interesting to realize that CMV actually was correlated with a reduction of chances to have long COVID. So so it's not every virus. It's clearly something about EBV that's lingering there and doing its damage. So the other study that came out a couple of months ago was looking at a different cohort, and in this case, it's people who had EBV. They had MECFS, and then had COVID. And so the investigators were interested to see what happens, and of course, these are people who, in this case, were diagnosed with MECFS before. So what we can see is that, and they were looking at a bunch of viruses, mostly from the herpes virus family. and including some endogenous retroviruses, like human endogenous retrovirus K. And what they did here, which is quite unique, they did it in saliva. So not in blood, but really in saliva, which turns out to be more sensitive. So ultimately, what we see is that there's a sort of a chronic fingerprint of elevated response to EBV even before COVID. So that really is related to the MECFS background. But specifically, COVID is actually a trigger for reactivation, specifically of EBV and for human herpes virus 6, as well as the endogenous retrovirus K. So those are all reactivated by COVID in the background of an existing MECFS. So clearly there's a worsening of symptoms as a result of that. So I think it's important to kind of the other takeaway message from this study is that saliva actually may be the place to look for reactivation, not necessarily the blood, that may be even more sensitive. I want to switch to talk about a different study that some of you have seen in main kind of mainstream media. The headlines were that an old drug called metformin, which is used for diabetes, has reduced the risk of long COVID. In this case, the title actually doesn't really tell the whole story, so I wanted to get into this research study in more detail. On the one hand, it's a wonderful study, and the reasons for that is that the investigators did a really unique effort in the context of COVID to look at three what we call repurposing drugs. So these are all drugs, they're all generic, they're quite cheap, and those are metformin, that's used in diabetes, fluvoxamine, that's used in for mental health, and ivermectin that I'm sure at this point I don't even need to tell you about. And what they did was, and the title is kind of interesting, they call it a multi-center randomized quadruple-blind parallel group phase 3 trial. But really probably the most interesting feature is that it was a decentralized study, which means that participants actually didn't really need to go to a clinic. If they were diagnosed with an acute COVID-19 infection and they were enrolled into that study, they immediately got the drugs sent home so that they can start the treatment right away. And they did this in a blinded fashion, so the physicians didn't know what the participants were getting, the participants didn't know what they were getting, and that was true for all those essentially 4 groups, placebo and the 3 repurposed drugs. So kind of complicated, but really achieved a wonderful, they were able to do this wonderful study. And what did we see? So, and maybe before we talk about that, just one other feature is that because of really what they were trying to do initially was just try to see if these drugs actually prevent acute COVID or severe acute COVID, and so they did that in a high-risk population. So these were all obese patients or overweight patients and other aspects of their clinical features which made them at a high risk for severe COVID, but primarily they were all overweight. And so the results were that if you took metformin when you were sick, you had 41% chances or less than getting long COVID if you only took the placebo. The real numbers were that 6.3% of people who took metformin developed long COVID, as opposed to the 10.4% of people who had received the placebo, which is much closer to what we know is the actual number of people who are diagnosed with long COVID, which is in the 15% range. The difference was even greater, so it was 63% lower chances of getting long COVID if you actually took metformin in the first days. The first 3 days after you got the exposure. So, it's a study that we can get excited about. I think if we think about metformin, it's a fairly benign drug. It does have side effects, but it's a very well characterized drug. So I think the risk is known. And so if you had COVID and you were at high risk, a short course of metformin is probably a good thing to do. It's inexpensive. And certainly, would probably be in the category of what Paxlovid does. So certainly a good option. I think, a lot of people kind of looked at long COVID and said, well, can we extend that to MECFS? Because we saw the similarity between MECFS and long COVID. So, does that really tell us something about the use of metformin in long COVID? And here's where I think I would caution us to kind of look at this study in a more limited way. I think really all it tells us is that if you use metformin very early on, it probably has an effect on the acute disease. I don't really see that as something that that goes beyond that. And the definition of long COVID in this study is really basically the participants were asked if their primary care physician or their healthcare provider gave them a diagnosis of long COVID. And in most cases, healthcare providers will reach this diagnosis if people are complaining about, the persistent cough, the loss of sense of smell and taste, those things that we talked about earlier as being more related to the COVID infection itself. So I don't know at this point, that there's any evidence from this study that can guide us into using metformin in MECFS. It's an open question. It's a drug that has been described in this context in the past, but I don't know that this study really gives us any evidence to guide us in that direction. So a study that got a lot of attention. That's really what I can learn from that. So the key take-home messages, I think, from all of these studies that I think at this point it is very clear that MECFS, it's a subset of long COVID. Not everyone, but probably a significant proportion, maybe at least half, maybe 3/4 of people with long COVID would meet the clinical diagnostic criteria for MECFS. They could also, at the same time, they could also have dysautonomia. They could also be diagnosed with autoimmune diseases. So it doesn't really preclude that. And I think with the heightened awareness now, we may finally understand the overlap between MECFS and these other diagnoses. In addition to that, I think EBV, Epstein-Barr virus, really emerged as a key factor in long COVID. It's what we can define as a disease modifier at the very least. In other words, if you had COVID, EBV reactivation will alter and modify the way that you may experience long COVID, and that just highlights how inadequate are our current tools for diagnostic purposes and also for treating EBV with antivirals. We just don't have good tools. So I think what I'm going to be saying more and more, in the coming months, to whoever we talk to, is that if we're now learning from the past and applying that to what we get from long COVID, it's the need for better antivirals, specifically for EBV, also for HH6, and better diagnostic tools. So hope this is helpful to kind of understand where we are. We continue to get a lot of information from COVID studies, and we'll keep track on how to make these connections to MECFS, and what breakthroughs do we get from this intense period of scientific and medical inquiry. Thank you, and we'll see you soon.